Welcome to the deep dive. Today we're digging into something pretty significant, affects a lot of people. Peripheral vascular disease, or PVD.
Right, PVD. And our sources, they frame it pretty clearly. It's essentially when the arteries, usually the ones going to your legs, they start to narrow.
Like plaque buildup.
Exactly. Atherosclerosis is the usual culprit. And this narrowing, well, it reduces blood flow. But the key thing, and you really need to get this, is that PVD is often a big red flag. It signals you're likely at higher risk for other major cardiovascular stuff, heart attacks, strokes, things like that.
Okay, got it. So our mission today is to wade through this pile of material. We've got, research guidelines, notes, and really focus in on the medications, the drugs used for PVD.
Yeah, we want to unpack what they are, kind of how they work, basically, and crucially, what the actual evidence says about using them. Does it back up the practice?
Makes sense. Because it seems like there are different angles, right?
Yeah.
Different types of drugs.
Totally. It's not just one thing. We'll be looking at meds that deal with blood clots, others that target those risk factors like cholesterol, blood pressure, and then some specifically for that leg pain, the walking pain.
Okay, let's unpack that big picture first. Before we dive into specific drug names, what are the main goals? Like, what are doctors trying to do with medication for someone with PVD?
Well, the sources point to a few main things. First, you want to slow the disease itself down. That means tackling the underlying risk factors, getting after those root causes.
Right.
Second, you've got to treat the symptoms that are actually impacting the person's life. That classic one is intermittent claudication, that cramping pain in the legs when you walk or exercise.
Okay, so slow it down, ease the symptoms.
And then maybe the most critical part from a survival perspective is preventing the really serious complications. We're talking mainly about those atherothrombotic events, clots forming on the plaque.
Which could lead to a heart attack or stroke or even losing a limb. Exactly. And finally, well, if one of those acute events does happen, you need meds ready to treat it right then and there.
Slow progression, treat symptoms, prevent disasters, and manage emergencies. Seems logical. And the drug categories we'll cover map onto those goals.
Pretty much, yeah. We'll be hitting the anti-thrombotics, that's the clot stuff, then cholesterol-lowering drugs, anti-hypertensives for blood pressure, specific meds for claudication, and maybe briefly touch on nutritional supplements, too.
All right, let's start with those anti-thrombotics. Preventing clots feels like ground zero, given the risks. What falls under that umbrella?
So the sources break it down. You've got your anticoagulants, your antiplatelets, the thrombolytics, the clot busters, and even this interesting one, dextrin, which has a kind of unique history here.
Different ways to stop clots.
Yeah. Each one interferes with the clotting process, but they target different parts of it.
Let's start with anticoagulants. How do they generally stop the bleeding? Stop the clotting. Right, stop the unwanted clotting. They generally work by inhibiting specific proteins, these clotting factors that are part of this whole chain reaction, the coagulation cascade. By blocking certain steps, they prevent the formation of fibrin. Fibrin is like the mesh, the structural net that makes a clot stable and strong. So no fibrin, no stable clot.
Okay. What are some of the key anticoagulants mentioned?
Well, the classic is warfarin. It's been around a long time, taken as a pill. It works by messing with vitamin K, which is needed to activate several key clotting factors, factors 2, 7, I, and X, plus some natural anticoagulant proteins, C and S.
Now, here's something I saw that seemed odd. With warfarin, you sometimes need another anticoagulant when you first start it. How does that work?
Yeah, it does sound backwards, doesn't it? But it's really important. See, warfarin inhibits protein C, one of those natural anticoagulants, relatively quickly. But factor 2, a major pro-clotting factor, sticks around for much longer.
So there's a lag.
Exactly. For the first few days, you can actually end up with less of the natural brake, protein C, while still having plenty of the accelerator, factor 2. This can weirdly make you more prone to clotting temporarily.
Oh, wow.
So that's why you often start something like heparin alongside warfarin for those first few days, bridging the gap until the warfarin has really knocked down factor 2 levels enough, which can take, 8 days, maybe even 15 days for the full effect.
That's a fascinating bit of pharmacology. What about the newer ones, the direct inhibitors?
Right, so you have the direct thrombin inhibitors. Argatroban is one, given 4, and dabigatran is an oral one. They're more straightforward. They latch directly onto thrombin, which is factor 2, and block it. Simple as that.
Okay.
And then there are the factor As inhibitors.
Yeah.
Apixaban, rivaroxaban, those are oral, and fondaparinux, which is an injection. Factor As, another critical point in that cascade.
And they work directly on Zaca.
Apixaban and rivaroxaban do, yes. They bind right to it. Fondaparinux is a little different. It's indirect. It boosts the body's own antithrombin third, and that complex mainly goes after factor XAN.
Got it. And heparins.
Yeah.
I feel like I've heard of those more.
Yeah, they're very common. You have unfractionated heparin, UFH, and the low molecular weight heparins, LMWHs. They're also indirect. They work by binding to antithrombin the third and making it way more powerful.
So they supercharge the body's natural system.
Kind of, yeah.
Right.
The UFH-83 complex targets several factors, but mainly thrombin, ADA, and factor XA. UFH works fast, especially for the LMWHs, like enoxaparin, are smaller heparin fragments. They also boost AT3, but they tend to focus more on inhibiting factor XA than thrombin. They're given as shots under the skin.
So many different ways to tackle clotting. When do the sources say these are actually used in PVD patients?
Okay, this is where it gets nuanced. For just keeping a standard leg bypass graft open long-term after surgery, anticoagulants like warfarin generally aren't the first choice.
Really? Why not?
The evidence for benefit isn't super strong, and the risk of bleeding goes up quite a bit. A single anti-platelet drug is usually preferred there.
Okay. What about after removing a clot?
They might be used short-term, say for about 3 months, after a procedure, like a thrombectomy, to try and stop the clot from forming again right away, often starting with heparin, then switching to warfarin.
But not necessarily long-term.
Right. The sources mention there's some debate about keeping someone on warfarin long-term after that 3 months if there isn't another clear reason, like atrial fibrillation causing clots elsewhere. Guidelines seem to have moved away from routine long-term use unless the bleeding risk is really low.
And you wouldn't just add one to an antiplatelet for general heart protection in PVD?
Generally, no. Not unless there's another specific indication for the anticoagulant, like AFib or a history of DVT or PE. The added bleeding risk usually outweighs the benefit for just PVD risk reduction.
Okay, so not routine for prevention or general risk unless something else is going on. What about specific situations? Acute problems?
Definitely. There's a condition called HIT, heparin-induced thrombocytopenia. It's tricky. Your body makes antibodies to heparin that actually cause clots. If someone has active HIT and needs anticoagulation, argatroban is often used. Fondaparinux might be an option if there's a history of HIT.
And the newer oral ones? Apixaban, rivaroxaban.
They're frequently used for treating DVT or PE or preventing stroke in people with atrial fibrillation. A big plus is usually less monitoring than warfarin. Although the sources did initially flag the lack of readily available reversal agents as a concern, though that's changing now.
And heparin itself?
Yeah.
UFH or LMWH?
They come in when you need something fast. UFH is kind of the standard for acute limb ischemia, a sudden severe blockage to stop the clot getting worse while you figure out the next step.
Like emergency treatment?
Exactly. And UFH is also routinely used during vascular surgery itself to prevent clots forming while the surgeons are working on the vessels. LMWH can be used too, but UFH is common intraoperatively.
Okay, that covers anticoagulants. Let's shift gears to the antiplatelets. These seem more focused on preventing heart attacks and strokes, right?
Precisely. Remember, PVD means plaque, and that plaque isn't just in the legs. It's often in the heart arteries, the coronary arteries, and the neck arteries, the carotids too.
And platelets are involved in clots on that plaque.
Key players. When plaque ruptures, platelets rush in, stick together, and form a clot that can block the artery, causing a heart attack or a stroke or a TIA. And our sources really hammer this home. Heart attack and stroke are the main killers in PVD patients, so antiplatelet therapy is absolutely vital.
What are the main players in the antiplatelet world?
Aspirin is the big one, the classic. Then you've got Clopidogrel and an older related drug, clopidine. There's also a combo pill, the pyridamol, plus aspirin brand name Agrinox sometimes.
Right.
And another one, Clopidogrel, though the sources note it's mainly studied in acute heart situations, not specifically just for long-term PVD management yet.
How do they work? Aspirin first, how does it stop platelet sticking?
Aspirin basically jams up a key enzyme inside platelets called KOX1. It does this irreversibly. Blocking KOX1 means the platelet can't make thromboxane A2.
Thromboxane A2?
Yeah, it's a powerful chemical signal that tells other platelets to clump together, and it also constricts blood vessels. Low doses of aspirin, like the 81 milligram baby aspirin, are usually enough to shut down KOX1 in platelets pretty effectively while minimizing side effects like stomach upset.
Okay. And clopidogrel? Clopidine.
They're a bit different. They're called phenopyridines, and they're actually prodrugs. Your liver has to activate them first. Once active, they irreversibly mess with a specific receptor on the platelet surface, the P2Y12 receptor.
P2Y12.
Right. It's a key docking point for another chemical signal, ADP, that tells platelets to aggregate. So blocking P2Y12 stops that signal. Taclopidine works similarly, but it has these risks of serious blood side effects, so it's hardly ever used now. Clopidogrel is much preferred.
What about dipyridamole?
It does a couple of things. It can relax blood vessels a bit, and it also makes platelets less sticky by increasing something called cyclic AMP inside them. But on its own, it's not really used for major event prevention.
Except in that combo pill, Agrinox?
Exactly. That specific combination, dipyridamole plus a very low dose of aspirin, 25 milligram, was shown to be better than aspirin alone for preventing another stroke in people who've already had a stroke or TIA. But that aspirin dose might be a bit low for preventing heart attacks, for instance.
Okay, understood. So that's the how. What about the why? What's the evidence for using antiplatelets in PVD?
Well, for keeping bypass grafts open after surgery, especially vein grafts, studies show aspirin helps. And if you get a prosthetic graft below the knee, one big trial, CAPRIE, found that adding clopidogrel to aspirin for the first year was significantly better than aspirin alone, so that's now a recommendation.
Can they help avoid needing surgery in the first place?
There's a hint of that. One large prevention study found low-dose aspirin reduced the need for peripheral artery surgery down the line, although interestingly, it didn't actually help with the leg pain symptoms themselves.
But the main reason is preventing those big cardiovascular events.
Absolutely. Large analyses, pooling data from many trials, including PVD patients, consistently show that antiplatelet therapy significantly cuts the risk of having a heart attack, a stroke, or dying from a vascular cause. It's a cornerstone of risk reduction.
Okay, now, here's where I saw some, let's say, discussion in the sources. What about using aspirin for someone who has PVD confirmed, maybe by ankle pressures, but has no symptoms? Asymptomatic PVD.
Yeah, you've hit on a really tricky area. This is where the evidence gets murky and the guidelines actually differ a bit. There was a huge meta-analysis looking specifically at this question. Should you give low-dose aspirin to people with asymptomatic PVD? It found that yes, aspirin did significantly reduce the number of non-fatal heart attacks. That's the benefit. However, and this is the crucial trade-off, it also caused a significant increase in major bleeding events.
Like stomach bleeds?
Yeah, GI bleeds mainly, or other significant bleeds outside the brain. So you're preventing some heart attacks but causing some serious bleeds.
Which makes the decision harder.
Exactly. And that's why you see different recommendations. Some expert groups say yes, based on the overall picture, recommend low-dose aspirin, 75 to 100 milligram for asymptomatic PVD. Others look at that same data and say, well, the benefit isn't clearly established when you factor in the bleeding. And some are more neutral, saying it can be considered.
So it's not a slam dunk. It really highlights the uncertainty, doesn't it? And how guidelines evolve.
It really does. It becomes a conversation between the doctor and the patient about their individual balance of risks. How high is their heart attack risk versus their bleeding risk?
Okay. What about comparing aspirin directly against clopidogrel for reducing events in PVD?
There's a major trial called CAPRIE that did just that. It looked at a broad group of high-risk patients, including a big subgroup with PVD. Overall, clopidogrel came out slightly ahead of aspirin in preventing the combined outcome of ischemic stroke, heart attack, or vascular death.
And specifically in the PVD patients.
The difference was actually more noticeable in the PVD group. Clopidogrel showed a statistically significant greater reduction in events compared to aspirin in those patients.
So clopidogrel is better for PVD patients.
Technically, yes. Based on CAPRIE, it is more effective. But, the absolute difference in event rates is relatively small. We're talking maybe an 8–9% relative risk reduction overall compared to aspirin in broader analyses. So you have to weigh that modest extra benefit against the fact that clopidogrel is more expensive and has a slightly different side effect profile, maybe more rash or diarrhea, whereas aspirin is more known for GI upset and bleeding.
Okay, so let's try and summarize antiplatelet use in PVD.
All right. If you've had bypass surgery, aspirin is usually standard. If it was a prosthetic graft below the knee, add clopidogrel for a year. For general long-term cardiovascular risk reduction, aspirin is usually the first-line choice because it's effective, cheap, and well-studied.
And clopidogrel?
It's a great alternative, especially if someone can't tolerate aspirin. And given the CAPRIE PVD subgroup data, it's arguably a better choice for symptomatic PVD patients, though you balance that small extra efficacy against cost. Taclopidine, forget it. Too many side effects. Agrinox is really just for secondary stroke prevention.
This is the bottom line.
The bottom line is, almost everyone with symptomatic PVD should be on either aspirin or clopidogrel long-term to cut their risk of heart attack and stroke. For asymptomatic PVD, it's more of a nuanced discussion, often leaning towards considering aspirin but weighing individual risks carefully.
Okay, great summary. We've done anticoagulants and antiplatelets. What about the thrombolytics, the actual clot busters?
Right. These are the heavy hitters used to dissolve a clot that's already formed and causing a major blockage. Think acute limb ischemia, sudden, severe leg pain, and loss of pulse. Or sometimes used during procedures to clear out a clotted graft.
What drugs are we talking about?
Things like alteplase, reteplase, tenecteplase, these are versions of tissue plasminogen activator, or TPA. Older ones like streptokinase aren't really used much anymore.
And how do they bust the clot?
They work by activating the body's own clot-dissolving machinery. They convert plasminogen, which is floating around in the blood, into its active form, plasmin. And plasmin is like Pac-Man for fibrin. It just chews up the clot structure.
Sounds powerful. What's the catch?
Bleeding. Big time. If you're ramping up the system that dissolves clots everywhere, you risk bleeding anywhere. The site where the catheter is put in is common, but internal bleeding is the major concern.
How effective are they for, say, saving a leg with an acute blockage?
Well, studies comparing thrombolysis, usually given via a catheter right into the clot, versus emergency surgery have had kind of mixed results. Some early data suggested lysis might be better if symptoms were recent, maybe less than 2 weeks. But later, larger trials like TOPIAS found similar rates of limb salvage and survival at 1 year between lysis and surgery. However, those trials consistently showed significantly more major bleeding complications with thrombolysis.
Ah. So the risk side of the equation was higher.
Exactly. And based on that, guidelines actually shifted over time. While thrombolysis definitely still has a role, especially in certain centers or patients, surgery is often favored now for acute limb ischemia because of the lower bleeding risk profile overall. It's a perfect example of how trial data can really change practice, even for established treatments.
Fascinating. Okay, one more in this section. You mentioned dextrin as an interesting aside.
Yeah, dextrin's kind of cool. It's this sugary solution that was originally used mainly to expand blood volume, like after blood loss. But doctors started noticing this weird side effect.
It caused bleeding.
Sometimes, yeah, or interfered with clotting. It seems to mess with fibrin formation, reduce levels of certain clotting factors like factor VIII, and make platelets less sticky.
And they thought, hey, maybe we can use that.
Pretty much. They turned an adverse effect into a potential therapy. There's some evidence, particularly from older studies around carotid artery surgery, suggesting that giving dextrin perioperatively might help prevent small clots from forming and causing strokes. It's not FDA approved for that and not widely used now, but it's a neat piece of medical history observing an unexpected effect and repurposing it.
Okay, so that covers the antithrombotics, a complex area. Now, shifting focus. PVD is driven by atherosclerosis. Managing those underlying risk factors, cholesterol and blood pressure, must be absolutely key, right?
Oh, absolutely fundamental. You could argue it's the most important long-term strategy. The link between high cholesterol and clogged arteries, I mean, we've known about that for, 80 years, according to our sources? High LDL, the bad cholesterol, and low HDL, the good stuff, are major culprits, and almost all PVD patients have issues here.
And the main goal with cholesterol meds.
Job number 1 is getting that LDL cholesterol down aggressively.
Which leads us directly to statins.
Statins, yes. They are the absolute cornerstone, the bedrock of cholesterol management in PVD. Drugs like simvastatin, atorvastatin, rosuvastatin.
How do they work again?
They block a key enzyme in the liver, HMG-CoA reductase, that's needed to actually make cholesterol. By doing that, they not only reduce cholesterol production, but also make the liver pull more LDL out of the bloodstream.
And the impact is pretty big.
Huge. They can lower LDL by anywhere from, say, 18% to well over 50%, depending on the statin and the dose. They often give HDL a little boost too and lower triglycerides. But the real power, shown in massive trials like the heart protection study and baked into all the major guidelines, is that they significantly reduce the risk of heart attack, stroke, and dying from cardiovascular causes in high-risk people, like those with PVD.
And they help the plaque itself.
Yes, that's another benefit. They seem to help stabilize the existing plaque, making it less inflamed and less likely to rupture, which is what triggers those dangerous clots.
Are other cholesterol drugs ever used?
Sometimes, yeah, usually as add-ons if statins aren't enough or aren't tolerated. Fibrates are mainly used if triglycerides are very high. Bile acid sequestrants work in the gut to bind up bile acids, forcing the liver to use more cholesterol. Niacin, or vitamin B3, is great at raising HDL, but It often causes uncomfortable flushing, and it can be problematic for people with diabetes, which many PVD patients have, so it's not used as much despite the lipid effects. And then there's ezetimibe, which blocks cholesterol absorption from food in the intestine. It can be added to a statin for a bit more LDL lowering, but really, statins are the main event.
Okay, statins are essential for cholesterol. What about the other big risk factor? High blood pressure, hypertension.
Equally critical, high blood pressure just batters the artery walls over time, accelerates that atherosclerosis. So controlling blood pressure in PVD patients is vital, mainly for the same reasons as statins, to slash their risk of heart attack, stroke, heart failure, kidney disease, all those major cardiovascular outcomes.
What's the usual blood pressure target?
The general goal cited in guidelines is usually less than 140/90.
Now, here's a really important point I saw. Does lowering blood pressure actually help with the PVD leg pain, the claudication symptoms?
That's a crucial distinction the sources make. While absolutely vital for protecting the heart and brain, blood pressure medications, as a rule, are not effective for relieving intermittent claudication.
In fact, they might even make it slightly worse sometimes.
Yeah, there's a theoretical possibility, although large studies suggest it's usually not a clinically significant effect for most people. But the thinking is, in those narrowed leg arteries, the vessels below the blockage might already be maximally dilated, just trying to get enough blood through at rest.
So they can't open any further.
Right. And when you exercise, you need more flow. If you lower the overall driving pressure with medication, you might slightly reduce the flow that can get through during exertion. There's also this idea of a steal phenomenon. Lowering pressure might allow blood to flow more easily to healthier muscle beds, sort of stealing it from the area served by the diseased arteries.
So the really critical take-home message here is,
do not stop your blood pressure medication if your walking distance doesn't improve or even feels a tiny bit worse. The huge benefit these drugs provide in preventing heart attack, stroke, and death in PVD patients massively outweighs any potential minor impact on claudication. Cardiovascular protection is paramount.
Got it. So how do doctors choose which blood pressure drug for someone with PVD? Is there one class that's best?
Not really for the PVD symptoms themselves. The choice is mostly driven by the patient's other medical conditions. Do they also have heart failure, kidney disease, diabetes, asthma? That guides the selection. However, some classes have shown specific benefits in reducing overall cardiovascular events in high-risk populations, which definitely includes PVD patients.
And which ones stand out in the sources for that broader impact?
ACE inhibitors and beta blockers get a lot of attention. ACE inhibitors, drugs like ramipril and enalapril, lisinopril, they block the production of angiotensin II, which is a potent substance that constricts blood vessels and drives up pressure.
And there was something special about ACE inhibitors, wasn't there? Beyond just lowering pressure.
Yes. The CAPRIE study, a real landmark trial. It included a lot of PVD patients and found that ramipril significantly reduced heart attacks, strokes, and cardiovascular deaths. And this benefit seemed to go beyond what you'd expect just from the blood pressure lowering itself.
An independent protective effect.
Exactly, and that's a major reason why ACE inhibitors are often considered a first-line choice for hypertension in many PVD patients. They offer this extra layer of cardiovascular protection. Of course, they have potential side effects like cough or affecting kidney function, so monitoring is needed.
Okay. What about beta blockers? Like metoprolol, atenolol? I thought there used to be a concern they were bad for PVD symptoms.
You're right, that was a long-standing worry based on older reports and theoretical concerns. Beta blockers work by slowing the heart rate, reducing how hard the heart pumps, and lowering renin release, all leading to lower blood pressure.
But the worry was they'd worsen leg circulation.
Yes, the fear was they might constrict peripheral arteries or reduce flow. But newer, better studies and meta-analyses have largely debunked that for most patients. They found that beta blockers generally do not significantly decrease walking distance or worsen symptoms in people with mild to moderate PVD. They can usually be used safely. Maybe still use caution in someone with really severe limb-threatening ischemia, but for most, they're okay.
Okay, so the old fear was mostly unfounded. But is there a positive reason to use them in PVD?
Absolutely, a huge one, especially around surgery. Multiple studies, like those by Poldermans and Mangano mentioned in our sources, showed that giving beta blockers to high-risk PVD patients undergoing vascular surgery significantly reduced their risk of having a heart attack or dying around the time of the operation.
So they protect the heart during surgical stress.
Precisely. Because of this strong evidence, they're often continued if a patient is already on them, or even started before surgery specifically for this cardioprotective benefit in high-risk individuals. Like all drugs, they have contraindications of very slow heart rate, certain types of heart failure, asthma, but they play a key role perioperatively.
And quickly, other common BP meds like calcium channel blockers or diuretics.
Yeah, they're definitely used too, again, based on comorbidities. Calcium channel blockers relax blood vessels. Some also slow the heart rate. Diuretics help flush out salt and water to lower blood volume and pressure. The specific choice depends on the whole clinical picture, aiming for that 1490 goal while maximizing the overall cardiovascular risk reduction.
Okay, we've covered the foundations: preventing clots and events, managing cholesterol and blood pressure. Now, let's zero in on the symptom itself, that intermittent claudication, the leg pain with walking. We know BP meds don't help it, and simple vasodilators might even backfire. So what is used specifically for that?
Right. The old strategy of just trying to dilate the leg arteries didn't pan out well, sometimes causing that steal effect. Our sources really highlight two main drugs that have been specifically studied and used for improving walking distance in PVD, pentoxifylline and salicizol.
Let's take pentoxifylline first. How is it supposed to work?
The idea behind pentoxifylline was that it might improve blood flow characteristics, making the blood less viscous or thick, and making red blood cells more flexible so they could squeeze through narrowed areas better. It also had some mild anti-platelet effects.
Okay, sounds plausible. Did it work? Yeah.
When researchers pooled all the studies together in meta-analyses, they found that, yes, there was a statistically significant improvement in walking distance compared to placebo, but the improvement was generally pretty small and quite variable between studies.
So not a dramatic effect.
Not really. The clinical significance, like, does it make a real difference in a patient's daily life, was questioned. And because the evidence is considered weak and conflicting, major guidelines, like the ACCP ones cited, now specifically recommend against using pentoxifylline for treating claudication in PB.
Okay, so pentoxifylline is basically out. What about the other one, cilostazol?
Cilostazol is different. It's a phosphodiesterase inhibitor, specifically PDE3. This gives it a range of effects. It inhibits platelet aggregation, it causes vasodilation, it seems to have some beneficial effects on lipid profiles, and might even help prevent smooth muscle cells from multiplying in the artery wall, which contributes to narrowing.
A multi-pronged mechanism. And what does the evidence show for walking distance?
Much more positive. Multiple well-conducted randomized controlled trials have consistently shown that cilostazol leads to significant improvements in walking distance, both how far people can walk before the pain starts and the maximum distance they can walk.
Better than pentoxifylline?
Yes. There was even a head-to-head trial comparing the two, and cilostazol came out significantly more effective than pentoxifylline at improving walking distance.
So the recommendation for cilostazol is?
Based on this strong evidence, guidelines recommend cilostazol as a treatment option for patients who have disabling intermittent claudication, meaning the leg pain really limits their function and quality of life, and who haven't gotten enough benefit from lifestyle changes and exercise, and aren't immediate candidates for revascularization procedures like stenting or surgery.
So it's the go-to drug if medication is needed for claudication symptoms?
Pretty much, yes. Pentoxifylline is off the table, cilostazol is the evidence-based choice. But, and this is a really important but emphasized in the sources,
What's that?
medication is not the first step for claudication. Before even thinking about cilostazol, the patient absolutely needs to address risk factor modification, stop smoking, manage diabetes and blood pressure, cholesterol, and, crucially, participate in a structured, supervised exercise program.
Exercise therapy itself helps.
Tremendously. Supervised exercise training is one of the most effective treatments for improving walking distance in PVD. Cilostazol should be considered an addition to these lifestyle foundations, not a replacement for them.
That's a critical point. Lifestyle first. Yeah. Okay, were there any other supporting treatments or supplements mentioned?
Just a brief note on nutritional supplements, specifically related to homocysteine.
Homocysteine.
Yeah, it's an amino acid. Some studies suggest that having high levels of homocysteine in the blood might be an independent risk factor for atherosclerosis. Your body needs certain B vitamins, specifically B6, B12, and folic acid, to properly metabolize homocysteine.
So taking B vitamins might help.
If someone is found to have high homocysteine levels, hyperhomocystinemia, supplementing with these B vitamins can help lower those levels. It's considered a way to manage that specific potential risk factor, though the overall impact on PVD events is still debated.
Got it. Okay, wow, we've covered a lot of ground: anticoagulants, antiplatelets, thrombolytics, statins, BP meds, claudication drugs. So pulling it all together, what does this mean for you, the listener, if you or someone you know has PVD?
I think the biggest takeaway is that managing PVD effectively isn't about finding one magic bullet. It's a comprehensive, multi-pronged strategy. You have to tackle it from different angles.
Like fighting on multiple fronts.
Exactly. You're fighting to slow down the underlying disease progression by hitting those risk factors: hard cholesterol with statins, blood pressure with appropriate meds. You're fighting to prevent catastrophic events like heart attacks and strokes, primarily using antiplatelets like aspirin or clopidogrel. And then, if needed, you're addressing specific symptoms like claudication to improve daily function, maybe with cilostazol after lifestyle changes.
And the specific mix of medications is going to be different for everyone.
Highly individualized, it absolutely depends on your specific situation. Do you have symptoms? How bad are they? What are your other health conditions? Have you had surgery or stents? What's your bleeding risk versus your clotting risk? It's a tailored plan, and it often needs adjusting over time.
But the overarching goals are pretty consistent, right? Slow the disease, improve quality of life, and protect against those major cardiovascular events down the road.
That's the name of the game. Keep the arteries as healthy as possible for as long as possible, let people live well, and prevent the things that can shorten life or cause major disability.
This deep dive really brought home just how complex this is, but also how dynamic. The understanding keeps evolving, doesn't it?
It really does. Seeing how guidelines have shifted on things like anticoagulation after surgery or beta blocker safety or the use of thrombolysis versus surgery, based on new trial evidence, it shows that medicine isn't static. We're constantly learning and refining how best to use these powerful tools.
And even with well-known drugs, there are still areas of debate, like that asymptomatic aspirin question. Balancing risks and benefits is rarely straightforward.
Absolutely. It underscores that managing chronic conditions like PVD isn't just about following a simple flowchart. It involves judgment, understanding nuance, and considering the individual patient.
So, reflecting on all this complexity, the changing evidence, the need for individualization, what does that really highlight for you, the listener, about the importance of your relationship and ongoing conversations with your own healthcare team?
That ongoing dialogue, that shared decision-making seems absolutely paramount, doesn't it? Staying informed, asking questions, understanding the why behind your specific treatment plan, that partnership is key to navigating this successfully.
A perfect thought to end on. Thank you so much for joining us for this deep dive into the medications for peripheral vascular disease. We hope this sheds some light on a complex but important topic.
Yeah, hope it was helpful. Stay curious.
We'll catch you on the next deep dive.